Hello, everyone. Before we start, make sure to like and subscribe to the channel and leave a comment with where you're from and what time you're watching. That way, YouTube will keep showing you stories just like this one. Now, let's begin. I'm a psychiatric ward doctor at Riverside State Hospital in Portland, Oregon, or at least I was until I submitted my resignation 3 weeks ago. You can call me Dr. Sarah Chen if you want, though most people in the psychiatric unit just called me Doc during my 9 years there. I've seen everything you can imagine in psychiatric medicine: severe depression, bipolar episodes, schizophrenic breaks, suicide attempts, violent psychotic episodes, and every kind of mental health crisis the human mind can experience. But what I'm about to tell you about is the one case that made me question everything I thought I knew about the boundaries between reality and delusion, and ultimately led me to leave the profession entirely. Riverside State Hospital is a 400-bed psychiatric facility serving the greater Portland metropolitan area and parts of southwestern Washington. It's a sprawling complex built in the 1960s with multiple secure units that handle everything from voluntary admissions to court-ordered commitments. During my time there, I worked primarily in the acute care unit, a 40-bed ward that served as the first point of contact for patients experiencing severe psychiatric emergencies. The acute care unit was where we saw the most unpredictable and challenging cases. Patients would arrive via ambulance, police transport, or emergency department transfers, often in various states of crisis. Some came voluntarily seeking help, while others were brought against their will during psychotic episodes or after suicide attempts. My role was to conduct initial psychiatric evaluations, stabilize patients medically and psychologically, and determine appropriate long-term treatment plans. Working in acute psychiatric care requires a specific type of mental resilience. You learn to maintain professional composure while witnessing human suffering at its most raw and vulnerable state. You develop the ability to distinguish between genuine psychiatric symptoms and manipulative behavior, between medication side effects and underlying pathology, between treatable conditions and chronic degenerative disorders. After 9 years, I thought I had seen every possible presentation of mental illness and developed the clinical judgment to handle any situation that walked through our doors. The case I'm about to describe began on October 23, 2023, during what started as a routine Monday evening shift. I had arrived at 3:00 p.m. for the afternoon handoff, where the day shift psychiatrists briefed us on current patients, new admissions, and any concerns that needed immediate attention. It was a relatively quiet period for our unit. We had 32 patients out of our 40-bed capacity, which was actually lighter than our usual occupancy rate. Most of our current patients were dealing with familiar presentations. A 45-year-old man with treatment-resistant depression who had been admitted after a serious suicide attempt. A 28-year-old woman experiencing her third manic episode in 2 years, refusing medication compliance. An elderly gentleman with early-stage dementia and increasing paranoid ideation. A teenage girl with severe anorexia nervosa whose weight had dropped to dangerous levels. These were challenging cases, certainly, but they fell within the scope of standard psychiatric care. Dr. Michael Rodriguez, the day shift supervisor, was finishing his report when his pager went off at 3:47 p.m. He glanced at the message and looked up at our team with a slightly puzzled expression. "We have an incoming admission, ETA about 20 minutes. Adult female, approximately 25 years old, brought in by Portland police after a welfare check. The preliminary information is unusual. The officers found her sitting in the middle of Southeast Division Street at 2:08 a.m. this morning, completely calm, not responding to traffic or attempts to communicate. No identification, no signs of intoxication or obvious medical distress. She's been at OHSU emergency for the past 12 hours for medical clearance, and they're sending her here for psychiatric evaluation. What makes this case interesting," Dr. Rodriguez continued, "is that she hasn't spoken a single word to anyone since she was found. Not to the police, not to the emergency department staff, not to the social workers who tried to interview her. She's physically cooperative, follows simple commands like sit down or stand up, but she won't speak or acknowledge questions. Medical workup was completely normal. no drugs, no alcohol, no signs of head trauma or neurological issues. I volunteered to handle the intake evaluation since I had experience with catatonic presentations and selective mutism cases. Sometimes patients experiencing severe trauma or psychotic episodes would present with mutism as a protective mechanism. Other times, it could indicate a neurological condition that hadn't been detected in initial medical screening. My plan was to conduct a comprehensive psychiatric evaluation, assess for signs of catatonia or other movement disorders, and determine whether we were dealing with a psychological or medical condition. The ambulance arrived at 4:15 p.m., and I met the patient in our intake area, along with two of our psychiatric technicians, James Morrison and Linda Park. What I saw immediately struck me as unusual for the typical presentations we encountered in acute psychiatric care. The patient was a young woman who appeared to be in her mid-20s, with shoulder-length dark brown hair and pale skin. She was wearing clean, well-fitted clothing, dark jeans, a gray sweater, and tennis shoes that showed minimal wear. Her appearance was neat and well-groomed, which was uncommon for patients who had been found wandering the streets in the early morning hours. Most people experiencing psychiatric emergencies severe enough to require police intervention show signs of self-neglect or disorganization in their appearance. But what struck me most about this patient was her posture and demeanor. She was sitting upright in the wheelchair provided by the paramedics, her hands folded neatly in her lap, looking straight ahead with a calm, almost serene expression. There was no agitation, no apparent distress, no signs of the anxiety or confusion typically seen in patients being admitted to psychiatric facilities against their will. "Miss, my name is Dr. Chen," I said, positioning myself directly in front of her wheelchair so we could maintain eye contact. "You're at Riverside State Hospital, and we're going to take good care of you. Can you tell me your name?" She looked directly at me when I spoke, her gaze steady and focused. Her eyes were a striking green color, and they showed clear intelligence and awareness. She wasn't staring blankly or showing the vacant expression often associated with catatonic states or severe psychotic episodes. But she didn't respond verbally to my question. "Can you nod if you understand what I'm saying?" I asked. She nodded once, clearly and deliberately. "Are you in any physical pain right now?" She shook her head. "Are you feeling scared or worried about being here?" She paused for a moment, as if considering the question, then shook her head again. This interaction told me several important things. The patient was clearly oriented and aware of her surroundings. She could understand spoken language and respond appropriately to yes or no questions. Her cognitive function appeared intact, but she was choosing not to speak, which suggested either a psychological reason for her mutism or possibly a medical condition affecting her ability to produce speech. I conducted a brief neurological examination right there in the intake area, testing her reflexes, coordination, and motor responses. Everything appeared normal. She could follow complex commands like touch your nose with your right hand, then touch your left ear. Her movements were smooth and coordinated, with no signs of the muscle rigidity or abnormal posturing associated with catatonic disorders. We transferred her to room 14, in the acute care unit, a private room where she would have some quiet space while we conducted our evaluation. The room had standard hospital furnishings: a bed, a small table and chair, a bathroom, and a large window that looked out over the hospital's courtyard area. Like all rooms in our psychiatric unit, it had been designed with safety in mind. No sharp corners, no removable fixtures, and a door that could be locked from the outside if necessary for patient safety. Once she was settled in the room, I began a more comprehensive psychiatric interview. Even though she wasn't speaking, I explained everything I was doing and continued asking questions to assess her mental status and gather information about her condition. "I'm going to ask you some questions about how you're feeling and what brought you here today," I told her. "Even if you don't want to speak out loud, you can nod or shake your head, or you can write down your answers if that would be easier for you." I offered her a notepad and pen, thinking that perhaps she had some physical or psychological barrier to speaking, but might be willing to communicate in writing. She looked at the notepad for a long moment, picked up the pen, and wrote something. Then she handed the notepad back to me. What she had written was a single word: waiting. Waiting for what? I asked, looking up from the notepad. She took the notepad back and wrote, "For someone to ask the right question." This response intrigued me because it suggested that her mutism was purposeful rather than the result of a psychiatric or medical condition. She clearly had thoughts and opinions about her situation, and she was capable of communicating them, but she seemed to have specific criteria for when and how she would engage with our staff. What would be the right question? I wrote on the notepad and handed it back to her. She read my question and sat quietly for several minutes, staring out the window at the courtyard. I waited patiently, watching her expression for any signs of internal struggle or decision-making. Finally, she wrote something and handed the notepad back to me. Her response was, "Do you believe that some people can see things that others cannot?" This question sent a chill down my spine, though I wasn't entirely sure why. In psychiatric medicine, questions about seeing things that others cannot typically indicate hallucinations, delusions, or other symptoms of psychotic disorders. But something about the way she had phrased it and the deliberate way she had been communicating suggested this wasn't a standard presentation of psychosis. I wrote back, "What kind of things are you referring to?" She read my question and then looked directly at me with those intense green eyes. For the first time since she had arrived, I saw something that might have been amusement cross her face. She wrote, "The kind of things that make doctors very uncomfortable." I decided to take a different approach. Rather than trying to pin down whether she was experiencing hallucinations, I wanted to understand more about her overall mental state and what had led to her being found in the middle of a busy street at 2 in the morning. "Can you tell me what you remember about last night?" I wrote. She took the notepad and wrote for a longer period this time. When she handed it back, her response was detailed. "I remember everything perfectly. I was exactly where I needed to be, doing exactly what I needed to do. The police officers thought they were helping me, but they interrupted something important." "What were you doing in the middle of the street?" I wrote. "Listening," she wrote back immediately. "Listening to what?" She paused again, staring out the window. Then she wrote, "To the voices of people who died on that exact spot over the past 50 years. Now we were getting somewhere." This sounded like a clear indication of auditory hallucinations, possibly with paranormal or supernatural themes. Many patients experiencing psychotic episodes report hearing voices of deceased individuals, often believing they have special abilities to communicate with spirits or access information from beyond the physical world. But as I prepared to write my next question, something about her demeanor stopped me. She didn't have the typical presentation of someone experiencing active psychosis. Her affect was calm and appropriate. Her thought process seemed organized and logical. She wasn't showing signs of paranoia or fear about the voices she claimed to hear. Most patients who experience auditory hallucinations, especially ones involving deceased individuals, show significant distress about these experiences. "How long have you been able to hear these voices?" I wrote. "Since I was 7 years old," she responded. "But I learned very early not to tell people about it. Doctors don't react well to children who claim they can hear dead people talking." This response suggested a long history of what she believed to be supernatural experiences dating back to childhood. It also indicated that she had enough insight to understand that most people, particularly medical professionals, would view these claims as symptoms of mental illness rather than genuine abilities. I spent the next hour conducting a thorough mental status examination through our written communication. I assessed her orientation, memory, concentration, judgment, and insight. On every measure except for her claims about hearing voices, she appeared to have completely normal cognitive and psychological functioning. Her orientation was perfect. She knew the current date, the name of our hospital, the city we were in, and could accurately describe recent news events. Her memory was excellent for both recent and remote events. She could recall specific details about her interactions with the police officers, the emergency department staff, and our conversation from earlier in the evening. Her concentration was intact. She could perform mental arithmetic, spell words backward, and maintain focus during lengthy written exchanges. Most puzzling of all, her judgment and insight seemed remarkably good. She understood why her behavior might be concerning to others. She acknowledged that sitting in the middle of a busy street was dangerous and that most people would view her claims about hearing voices as signs of mental illness. She even demonstrated understanding of the legal and medical processes that had brought her to our facility. "Dr. Chen, can I ask you something?" she wrote during one of our exchanges. "Of course," I wrote back. "In your 9 years working here, how many patients have you met who were genuinely dangerous to themselves or others, versus how many were just different in ways that society doesn't understand?" It was a sophisticated question that demonstrated not only her awareness of psychiatric concepts, but also a philosophical understanding of the broader social context of mental health treatment. Most patients experiencing acute psychiatric episodes don't have the capacity for this kind of abstract thinking about the nature of mental illness and social norms. "That's a complex question," I wrote back. "Why do you ask?" "Because I think you're trying to figure out which category I belong in. And I want you to know that I'm not dangerous to anyone. I'm just trying to help people find peace." "What do you mean by helping people find peace?" She took a long time to respond to this question. I watched her face as she considered her answer, and I could see that whatever she was thinking about was emotionally significant for her. When she finally wrote her response, it was longer than any of her previous answers. "When someone dies suddenly or violently, especially in accidents or crimes, they sometimes get stuck. They can't move on because they have something important they need to communicate to the living world. I can hear them, and sometimes I can help them deliver their messages. Last night, there were 3 people who needed help. A man who died in a car accident in 1987 wanted me to tell his daughter that he wasn't angry about their last argument. A woman who was murdered in 2003 wanted her family to know where to find a letter she had written, but never sent. And a teenager who overdosed 5 years ago wanted his parents to understand that his death wasn't their fault." As I read her response, I felt a mixture of professional skepticism and something else I couldn't quite identify. From a clinical standpoint, this sounded like elaborate delusional thinking, possibly with grandiose themes about having special abilities to communicate with the deceased. But there was something about the specificity of her claims and the emotional sincerity with which she described these supposed interactions that gave me pause. "How do you deliver these messages to the families?" I wrote. "I don't," she responded. "That's the problem. I can hear what these people want to say, but I can't contact their families without sounding like a crazy person or a con artist. So they stay stuck, and I stay frustrated." Last night was different because all 3 of them were speaking at once, and it was so loud and urgent that I had to sit down right there and listen to everything they wanted to say. This explanation provided a rational context for her behavior, at least from her perspective. If she genuinely believed she could hear voices of deceased individuals, and if she felt responsible for helping them communicate with their families, then sitting in the street to listen to them would make sense within her belief system. But I was still dealing with the fundamental clinical question. Was she experiencing genuine psychotic symptoms that required medication and intensive treatment? Or was she someone with unusual beliefs who didn't actually pose a danger to herself or others? I decided to explore her insight and judgment further. "Have you ever been hospitalized for psychiatric treatment before?" I wrote. "No," she responded. "I've been very careful to keep this part of my life private. I work as a librarian, I live alone, I pay my bills, I don't bother anyone. The only reason I ended up here is because last night was overwhelming, and I made the mistake of trying to help in a public place." "What kind of work do you do as a librarian?" "I work at the Multnomah County Central Library in the research department. I help people find information for academic projects, genealogy research, historical investigations. I've been there for 4 years, and my supervisors have never had any complaints about my work performance." This information, if accurate, suggested that she was able to function normally in her daily life and maintain employment in a position that required intellectual capability and social interaction. Most people with severe psychiatric disorders that would require involuntary hospitalization have significant impairment in their ability to work and maintain independent living situations. I excused myself from the room and went to speak with Dr. Rodriguez about my initial assessment. I found him in the nursing station, reviewing charts and preparing for the evening shift change. "Michael, I need to get your thoughts on the new admission in room 14, I said, settling into the chair beside his desk. "The young woman who was found in the street? How's the evaluation going?" "It's complicated," I replied. She's communicating through writing, and her responses are detailed and coherent. Her mental status exam is completely normal, except for her claims about hearing voices of deceased individuals. No signs of thought disorder, no apparent delusions beyond the supernatural beliefs. Excellent insight and judgment about everything else. Sounds like it could be a delusional disorder with supernatural themes, Dr. Rodriguez suggested. Or possibly early-stage schizophrenia with preserved functioning. What's your clinical impression so far? That's what I can't figure out, I admitted. If I just read her responses without meeting her, I would say she's experiencing auditory hallucinations with grandiose delusions about having special abilities. But when I interact with her directly, she doesn't present like someone in an active psychotic state. She's calm, appropriate, insightful about how others perceive her. And she seems to understand the difference between her subjective experiences and objective reality. Dr. Rodriguez nodded thoughtfully. Sometimes we see patients with long-standing delusional beliefs who have learned to function despite their symptoms. The question is whether she poses any risk to herself or others, and whether she needs involuntary treatment or if she can be managed on an outpatient basis. That's exactly what I'm trying to determine, I said. She claims she works as a librarian and lives independently. If that's true, then we might be looking at someone with unusual beliefs who doesn't actually need psychiatric hospitalization. Let's verify her employment and get more background information, Dr. Rodriguez suggested. And I'd like you to observe her overnight to see if her presentation changes. Sometimes patients can maintain a facade during initial interviews, but show their true level of impairment over longer periods of observation. I returned to room 14 around 7 p.m. to continue my evaluation. The patient was sitting in the chair by the window, looking out at the courtyard where other patients were having their evening outdoor time. She had been given dinner, which she had eaten completely, and she had cooperated with all nursing assessments and routine procedures. I need to ask you some questions to verify the information you've given me, I wrote on the notepad. She nodded and took the pen. What's your full name and address? She wrote, Emma Rose Martinez. I live at 2847 Southeast Hawthorne Boulevard, Apartment 3B, Portland, Oregon, 97214. What's your supervisor's name at the library? Margaret Chen, Head of Research Services. No relation to you, I assume, based on your last name. I was struck by her attention to detail and her ability to provide specific, verifiable information. Most patients experiencing acute psychotic episodes have difficulty with this kind of factual recall, especially when they're in unfamiliar and stressful environments. Can I call your supervisor to verify your employment? She paused before writing her response. Yes, but please don't tell her about the voices. Just say that I'm in the hospital for a medical evaluation and that you need to verify my employment for insurance purposes. This request demonstrated sophisticated understanding of the social and professional consequences of psychiatric diagnosis. She was protective of her reputation and employment, which suggested she had insight into how her claims about supernatural abilities would be perceived by others. I spent the evening making phone calls to verify the information Emma had provided. Her landlord confirmed that she was a reliable tenant who paid her rent on time and had never caused any problems. Her supervisor at the library, Margaret Chen, described Emma as an excellent employee who was knowledgeable, helpful to patrons, and had never missed work without proper notice. According to Margaret, Emma was scheduled to work the next day, and it was unusual for her not to call if she couldn't come in. Everything Emma had told me about her life was accurate. She was exactly who she claimed to be, a functional, employed, independent adult who had never had any previous psychiatric treatment or legal problems. The only unusual thing about her was her belief that she could communicate with deceased individuals. And even that belief hadn't interfered with her ability to maintain normal relationships and responsibilities. But I still had the fundamental question of whether her claims about hearing voices represented genuine psychiatric symptoms that required treatment, or whether she was someone with unusual beliefs who had simply had an overwhelming experience that led to poor judgment about where and when to act on those beliefs. The answer to that question would determine whether she needed to remain in our facility for treatment or whether she could be safely discharged to continue her normal life. That night, I decided to conduct an overnight observation to see if Emma's presentation would change when she thought she wasn't being formally evaluated. Sometimes patients can maintain a composed facade during structured interviews, but reveal their true psychological state during unguarded moments. I arranged for our night shift psychiatric technician, David Kumar, to check on Emma every hour and document any unusual behaviors, vocalizations, or changes in her mental status. I also asked him to pay particular attention to whether she appeared to be responding to stimuli that weren't visible to staff, which would suggest active hallucinations. Around 11:30 p.m., I made my final rounds before heading home. Emma was lying in bed with the lights off, but she appeared to be awake and alert. When I quietly entered her room, she turned toward me and nodded in acknowledgement. "How are you feeling tonight?" I wrote on a small notepad, using the dim light from the hallway. She took the pen and wrote, "Tired, but the voices are quieter here. I think being away from that location has helped." "Are you hearing any voices right now?" "Just whispers. Nothing urgent like last night. Sometimes they get louder when I'm in places where traumatic events happened." This response suggested that her auditory experiences might be location-specific, which was an unusual feature if these were traditional psychiatric hallucinations. Most auditory hallucinations in schizophrenia or other psychotic disorders occur regardless of the patient's physical location. I left Emma to rest and drove home to my apartment in Northwest Portland. But I couldn't stop thinking about her case. Everything about her presentation challenged my standard approach to psychiatric diagnosis. She met some criteria for a delusional disorder, specifically the supernatural type, but she lacked the functional impairment and distress typically associated with that diagnosis. She claimed to experience auditory hallucinations, but her description of these experiences was more consistent with someone describing actual perceptions rather than the confused, fragmented reports typical of psychotic patients. The next morning, Tuesday, October 24th, I arrived at the hospital early to review David's overnight notes. According to his documentation, Emma had slept normally from approximately midnight to 6 a.m. She had awakened naturally, used the bathroom, and eaten breakfast without any behavioral concerns. She had been cooperative with all nursing procedures and hadn't displayed any signs of responding to internal stimuli or engaging in conversations with unseen individuals. Most significantly, David noted that around 3 a.m., he had observed Emma sitting by her window, writing in a notebook that she had requested from the nursing staff. When he asked what she was writing, she had shown him the notebook, which contained what appeared to be detailed descriptions of various locations around Portland, including dates and brief narratives about events that had allegedly occurred at those sites. I found this information fascinating because it suggested that Emma's beliefs about supernatural communication were systematic and detailed enough that she was documenting them in an organized fashion. This level of organization and record-keeping was unusual for someone experiencing active psychotic symptoms. When I entered Emma's room at 8 a.m., she was sitting at the small table, writing in the notebook David had mentioned. She looked up when I entered and handed me the notebook without my having to ask for it. What I read was extraordinary in its specificity and internal consistency. Emma had written detailed accounts of alleged supernatural communications she claimed to have received over the past several years, organized by location and date. Each entry included the supposed identity of the deceased individual, the circumstances of their death, and the message they wanted to convey to living family members. One entry read, "Pioneer Courthouse Square, southwest corner near the Max stop. April 15, 2022. Margaret Schultz died February 3, 1978, age 34, hit by a bus while crossing the street. She's been trying to tell her son David that the music box in her bedroom contains letters from his biological father. She wants him to know that she never stopped loving his father, but that she made the right choice by not telling him about the pregnancy because his father was married and had his own family." Another entry was equally detailed. Burnside Bridge, East Side Pedestrian Walkway. September 8, 2023. Kevin Rodriguez died June 12, 2019, age 27, suicide by jumping. He wants his parents to understand that his decision wasn't because of anything they did or didn't do. He had been hearing voices telling him to hurt other people, and he chose to hurt himself instead because he didn't want to become dangerous. He wants them to stop blaming themselves and to get help for his younger brother who is starting to show similar symptoms. I read through dozens of these entries, each one containing specific names, dates, locations, and detailed personal information about the alleged deceased individuals and their families. The level of detail was remarkable, and the internal consistency of Emma's narrative was impressive from a purely literary standpoint. But what struck me most was the emotional tone of these entries. They weren't written with the grandiosity or excitement typical of delusional thinking. Instead, they read like the careful documentation of someone who felt burdened by information they couldn't verify or act upon. There was a sense of sadness and frustration throughout her writing that suggested she genuinely believed these communications were real and felt responsible for helping these individuals find peace. Emma, I wrote, these entries are very detailed. How do you remember so much specific information about each person? I write everything down as soon as it happens, she responded. If I don't document it immediately, I start to doubt myself, and then I worry that I'm not helping them properly. Have you ever tried to contact the families mentioned in these entries? She paused for a long moment before writing her response. A few times, years ago, I would call and say I had information about their deceased relative, but they would either hang up immediately or become angry and accuse me of being a scam artist trying to take advantage of their grief. One family threatened to call the police on me. After that, I stopped trying. This response demonstrated remarkable insight into how her claims would be perceived by others and showed that she had learned from negative social consequences. Most patients with delusional disorders lack this kind of social awareness and continue to act on their beliefs despite repeated failures or rejection from others. What do you think would happen if I tried to verify some of the information in your notebook? You mean call the families or look up public records about the deaths? She wrote. Yes, exactly that. She looked thoughtful for several minutes before writing, I think you would find that the deaths I've described actually happened on the dates and in the circumstances I've documented. But I also think you would conclude that I must have researched this information somehow, rather than accepting that I could have learned it through supernatural means. That's what any rational person would think. Her response showed sophisticated understanding of scientific skepticism and the burden of proof required for extraordinary claims. She wasn't naive about the implications of her beliefs, and she wasn't trying to convince me that her experiences were real. Instead, she seemed resigned to the fact that others would find logical explanations for any evidence that supported her claims. I decided to test her prediction. With Emma's permission, I spent the afternoon researching the cases she had documented in her notebook. I started with the most recent entries, figuring that if these were real deaths, there would be public records, newspaper articles, or online obituaries that I could verify. What I discovered was deeply unsettling. Every death Emma had described in her notebook was real. The dates, ages, circumstances, and even the specific locations she had mentioned were accurate according to public records and newspaper archives. Margaret Schultz had indeed died on February 3, 1978, at age 34, when she was struck by a bus while crossing the street near Pioneer Courthouse Square. Kevin Rodriguez had died by suicide on June 12, 2019, at age 27, jumping from the Burnside Bridge. But the most disturbing aspect wasn't just that these deaths were real. It was that many of the personal details Emma had included in her entries, details about family relationships and private circumstances, weren't available in public records or news reports. Information about Margaret Schultz's son David and his paternity, or Kevin Rodriguez's concerns about his mental health affecting his younger brother, weren't things that would be documented in obituaries or news articles. I called the Multnomah County Medical with Dr. Patricia Examiner's office and spoke Williams, whom I had worked with on previous cases involving psychiatric patients who had died by suicide. I explained that I was conducting a psychiatric evaluation and needed to verify some information about deaths that had occurred in recent, cautious about sharing years. Dr. Williams was helpful, but details beyond what was already in public records. However, she confirmed that the basic facts Emma had documented were accurate. More troubling, when I mentioned some of the specific personal details Emma had included in her entries, Dr. Williams noted that some of that information had been discussed during family interviews conducted as part of the death investigations, but it wasn't information that would be publicly available. Dr. Chen, she said. How did your patient come by this information? These are details that would only be known to immediate family members and our investigation team. I didn't have an answer for her question. From a rational standpoint, there were only a few possibilities. Emma could have somehow gained access to confidential investigation files, which seemed unlikely given her employment as a librarian and her lack of any connections to law enforcement or medical examiner personnel. She could have conducted extensive research into these cases and somehow discovered private family information through social media, public records, or other investigative methods. Or she could have had personal connections to these families that she hadn't disclosed to me. But none of these explanations felt entirely satisfactory. The sheer volume of detailed, accurate information Emma had compiled over several years suggested an enormous investment of time and resources in researching dozens of deaths and their associated family circumstances. And her emotional presentation, her apparent distress about not being able to help these families, didn't match the profile of someone who had fabricated this information for attention or personal gain. I returned to Emma's room that evening with more questions than answers. Her notebook had raised possibilities that challenged everything I thought I knew about the boundaries between psychological symptoms and genuine anomalous experiences. Emma, I wrote, I've spent the day researching some of the cases in your notebook. She looked up from the book she was reading and nodded as if she had been expecting this. The deaths you've documented are real. The dates, locations, and circumstances are accurate according to public records. I know, she wrote. I wouldn't lie about something like that. But some of the personal information you've included isn't available in public sources. Details about family relationships and private circumstances that weren't reported in news articles or obituaries. She set down her book and took the pen. That's because the people who are speaking to me share information about their lives and their families. They want their loved ones to know things that were never made public. How would I be able to verify information that isn't in public records? You would have to contact the families directly and ask them if the personal details I've documented are accurate. But you won't do that because it would be unethical to disturb grieving families based on the claims of a psychiatric patient. Once again, Emma demonstrated remarkable insight into the practical and ethical constraints that limited my ability to investigate her claims. She understood that even if she was telling the truth, the nature of her claims made them essentially unverifiable through conventional means. But her response also revealed something else that concerned me. She seemed to have resigned herself to the fact that no one would believe her, and that resignation suggested a level of social isolation and emotional burden that was affecting her quality of life, even if it wasn't impairing her ability to function in basic ways. Emma, I wrote, regardless of whether these experiences are real or not, they seem to be causing you distress. Have you ever considered that you might be happier if you found ways to reduce or eliminate these experiences? She thought for a long time before responding. Dr. Chen, if you could hear people calling for help and you had the ability to help them, would you want to stop hearing them just because it was easier for you? It was a profound ethical question that reframed her entire situation. If Emma genuinely believed she was hearing deceased individuals who needed help communicating with their families, then from her perspective, her experiences weren't symptoms to be treated, but rather a responsibility she felt obligated to fulfill. But what if you could help them in some other way? I wrote. What if there were methods for you to assist these individuals without putting yourself at risk of psychiatric hospitalization or social isolation? What do you mean? She wrote. I wasn't entirely sure what I meant. I was operating outside the bounds of conventional psychiatric practice, exploring possibilities that had more to do with spiritual counseling or paranormal investigation than medical treatment. But Emma's case had forced me to consider whether there might be alternative approaches to helping someone whose primary problem wasn't mental illness, but rather an unusual set of experiences that didn't fit into standard diagnostic categories. What if we could connect you with people who specialize in helping individuals who believe they have supernatural experiences? I wrote. People who wouldn't automatically assume you're mentally ill, but who might be able to help you find constructive ways to deal with these communications. Emma's expression brightened for the first time since I had met her. There are people like that, she wrote. I'm not sure, I wrote back honestly. But I think it's worth exploring. The question is whether you would be interested in that kind of help. and whether you feel safe enough to be discharged from the hospital while we look into those options." She nodded emphatically and wrote, "I would much rather work with someone who understands these experiences than stay in a psychiatric hospital where everyone thinks I'm delusional." That conversation marked a turning point in my approach to Emma's case. Instead of trying to fit her experiences into standard psychiatric diagnostic criteria, I began exploring whether there were alternative resources and support systems that might be more appropriate for someone in her situation. The next morning, I consulted with Dr. Rodriguez about the possibility of discharging Emma with referrals to non-traditional support services. It was an unusual request that required us to think outside the standard protocols for psychiatric treatment. "Marcus," Dr. Rodriguez said, "I understand that this patient doesn't fit our typical diagnostic categories, but we have a responsibility to ensure that she's not a danger to herself or others before we discharge her. Are you confident that she can maintain her safety and continue functioning independently?" "Based on my evaluation, yes," I replied. "She's demonstrated good judgment about her safety, she's maintained employment and independent living for years, and her only risk behavior was sitting in the street during what she describes as an overwhelming episode. If we can help her develop better coping strategies for managing these experiences, I think she can avoid future incidents. What kind of referrals are you considering?" "That's where I need your input," I said. "I'm thinking about spiritual counselors, grief counselors who work with families of deceased individuals, maybe even researchers who study anomalous experiences. I know it's unconventional, but traditional psychiatric treatment doesn't seem appropriate for this case." Dr. Rodriguez was quiet for several minutes, clearly weighing the unusual nature of my request against the clinical evidence I had presented. Finally, he said, "I trust your clinical judgment, Marcus. If you believe this patient is safe for discharge and would benefit more from alternative support services than psychiatric treatment, I'm willing to support that recommendation, but I want you to follow up with her closely to make sure she remains stable." That afternoon, I began making calls to explore alternative resources for Emma. I contacted several grief counselors in the Portland area, explaining that I had a patient who believed she received communications from deceased individuals and was looking for someone who might help her process these experiences without automatically assuming they were symptoms of mental illness. Most of the counselors I spoke with were polite, but clearly uncomfortable with the unusual nature of my request. However, one counselor, Dr. Rebecca Martinez, who specialized in working with families dealing with sudden or traumatic deaths, expressed interest in potentially working with Emma. "Dr. Chen," she said, "I've worked with several clients over the years who have reported experiences similar to what you're describing. While I can't say whether these experiences are real or not, I've found that people who have them often benefit from having a safe space to process their feelings about these experiences without being pathologized. I'd be willing to meet with your patient to see if I might be able to help her." I also contacted Dr. James Harrison, a psychology professor at Portland State University who had published research on anomalous experiences and exceptional human experiences. Dr. Harrison explained that there was a small but growing field of research into people who reported supernatural or psychic experiences, but who didn't show signs of mental illness or functional impairment. These individuals often fall through the cracks of both the mental health system and the traditional religious or spiritual support systems, Dr. Harrison told me. They're not sick enough for psychiatric treatment, but their experiences are too unusual for conventional counseling. What they often need is validation that their experiences are real to them, and practical guidance on how to manage the social and emotional challenges that come with having experiences that others don't understand. By Thursday morning, I had arranged potential referrals for Emma to both Dr. Martinez and Dr. Harrison, pending her discharge from our facility. When I presented these options to Emma, her relief was palpable. "You found people who might actually understand," she wrote. "I can't guarantee that they'll believe your experiences are real," I wrote back, "but they're both professionals who specialize in helping people who have unusual experiences, and they're willing to work with you without assuming you're mentally ill." "That's more than I've had in 20 years, she wrote. "When can I meet with them?" "Before we arrange those meetings, I want to discuss some safety planning with you," I wrote. "If you continue to have overwhelming experiences like the one that brought you here, what will you do differently to keep yourself safe?" Emma thought carefully before responding. I think the problem was that I tried to handle 3 urgent communications at the same time in a public location. In the future, if I feel overwhelmed by multiple voices, I'll go to a private location where I can listen and document their messages without putting myself at risk of police intervention. That sounds like a reasonable plan, I wrote. But I also want you to have my contact information. And I want you to promise that you'll call me if you ever feel like you're losing control of these experiences, or if they start to interfere with your ability to work or take care of yourself. She nodded and wrote, I promise. And Dr. Chen, thank you for not trying to convince me that I'm crazy. Even if you don't believe in what I experience, you've treated me with respect and dignity, and that means more to me than you know. And that Thursday afternoon, I completed Emma's discharge paperwork with referrals to Dr. Martinez and Dr. Harrison, along with instructions for her to follow up with me in 1 week to assess how she was adjusting to being back in her normal environment. It was the most unconventional discharge I had ever processed, but it felt like the right clinical decision based on Emma's presentation and needs. As Emma gathered her belongings and prepared to leave the hospital, she handed me her notebook and said something that would haunt me for weeks afterward. Dr. Chen, she said, speaking aloud for the first time since I had met her. There's something I need to tell you before I leave. Last night, I heard a voice I hadn't heard before. Someone who died recently, and someone who has a message specifically for you. I felt my blood run cold as Emma spoke those words. In all my years of psychiatric practice, I had never had a patient claim to receive supernatural communication specifically directed at me. This was exactly the kind of escalation that suggested her condition might be more serious than I had initially assessed. Emma, I said carefully, I appreciate everything we've discussed over the past few days, but I think it would be better if we focused on getting you connected with Dr. Martinez and Dr. Harrison rather than exploring new claims about messages for me. She looked at me with those intense green eyes, and I could see something that might have been disappointment cross her face. I understand why you're uncomfortable, Dr. Chen. But this person is very insistent, and they say it's urgent. Despite my professional training and clinical skepticism, I found myself curious about what Emma thought she had heard. Who is this person supposed to be? I asked. A woman named Dr. Lisa Thompson. She says she was a psychiatrist who worked in this hospital until she died in a car accident 3 months ago. She has something important to tell you about a patient you both treated. When the name hit me like a physical blow. Dr. Lisa Thompson had indeed been a psychiatrist at Riverside State Hospital. She had worked in our adolescent unit for over 15 years until she was killed in a head-on collision with a drunk driver in July, just 3 months earlier. Lisa and I had been colleagues and friends. We had collaborated on several difficult cases over the years, and her death had been devastating to our entire staff. But what made Emma's claim even more unsettling was that there was no way she could have known about Lisa's death or our professional relationship. Lisa's death had been reported in the local newspaper, but it was a brief obituary that mentioned only her work at the hospital in general terms. There had been no public information connecting Lisa specifically to me or detailing our collaborative work on patient cases. How do you know about Dr. Thompson? I asked, trying to keep my voice steady. I don't know anything about her, Emma replied. She just started speaking to me last night around midnight. She said she's been trying to communicate with people in this hospital for months, but no one else can hear her. She was excited when she realized I could perceive her voice. What did she supposedly tell you about me? Emma hesitated, glancing around the room as if checking to make sure we were alone. She said that you and she worked together on a case involving a 17-year-old girl named Ashley Morrison who was admitted to the adolescent unit 2 years ago. She said Ashley died by suicide 6 months after being discharged, and that you've been blaming yourself ever since. I sat down heavily in the chair beside Emma's bed, feeling like the air had been knocked out of my lungs. Ashley Morrison had been one of the most challenging cases Lisa and I had ever worked on together. She was a brilliant teenager who had been admitted after a serious suicide attempt, and despite months of intensive treatment, she had taken her own life shortly after her 18th birthday. Lisa and I had spent countless hours analyzing Ashley's case, wondering if we had missed warning signs or if there was something different we could have done to save her. Ashley's death had haunted me for the past 1.5 years. I'd questioned my competence as a psychiatrist, wondered if I should leave the profession, and struggled with guilt about whether our treatment decisions had been adequate. But these were private thoughts and feelings that I had never discussed with anyone except Lisa, and certainly not in any public forum where Emma could have learned about them. Emma, I said slowly, even if Dr. Thompson was somehow communicating with you, which is medically impossible, how would you know specific details about cases we worked on together? Patient information is confidential. She told me that Ashley's case has been weighing on your mind and that she wants you to know that Ashley's death wasn't because of anything you or she did wrong. She said Ashley had made her decision long before she was admitted to the hospital and that the treatment you provided gave Ashley 6 additional months of life that she wouldn't have had otherwise. These words were almost exactly what Lisa had said to me during our last conversation about Ashley's case, just a few weeks before Lisa's own death. We had been reviewing Ashley's file, trying once again to understand if we'd missed something important, when Lisa had insisted that we had provided the best possible care under extremely difficult circumstances. Dr. Thompson also wanted me to tell you about the letter, Emma continued. What letter? I asked, though part of me was afraid to hear the answer. She said that before she died, she wrote you a letter about Ashley's case and about your work together. She was planning to give it to you when she returned from her vacation, but she never got the chance. The letter is in her office desk, in a sealed envelope with your name on it. She wants you to find it and read it. I knew that Lisa's office in the adolescent unit had been left largely untouched since her death. The hospital administration had been waiting for her family to come and collect her personal belongings, but her parents lived across the country and hadn't been able to make the trip yet. If there was a letter in her desk, it would still be there. Emma, I said, struggling to maintain my professional composure. I need you to understand that what you're describing is not possible from a medical standpoint. People who have died cannot communicate with the living. If you have accurate information about Dr. Thompson or Ashley Morrison, there must be a logical explanation for how you obtained that information. I know how this sounds, Dr. Chen. I know that everything I'm telling you contradicts your medical training and scientific understanding of death. But I also know that Dr. Thompson is standing right behind you, and she's nodding as I speak. She says she understands why you can't accept this, but she hopes you'll at least look for the letter. I turned around to look behind me, seeing only the empty hospital room with its standard furnishings and medical equipment. But I couldn't shake the feeling that something had changed in the atmosphere of the room, as if there was a presence I couldn't quite detect. She's gone now, Emma said quietly. She said she's used up all her energy trying to communicate and that she probably won't be able to speak to me again, but she wanted me to make sure I delivered her message. I spent the next hour completing Emma's discharge paperwork, but my mind was elsewhere. Everything Emma had told me about Lisa and Ashley was accurate, including private details that shouldn't have been accessible to anyone outside of our immediate treatment team. The specificity of her claims about a letter in Lisa's desk was particularly troubling, because it was something I could verify. After Emma left the hospital with her referrals to alternative support services, I found myself walking toward the adolescent unit. I told myself I was simply going to check on some routine administrative matters, but I knew that wasn't true. I needed to see if there was actually a letter in Lisa's desk. The adolescent unit was quieter than usual for a Thursday evening. Most of the patients were in group therapy or recreational activities, and the hallways had the subdued atmosphere that always reminded me of why I preferred working with adult patients. Lisa's office was at the end of the corridor, her nameplate still mounted beside the door. I used my master key to enter the office, which looked exactly as Lisa had left it 3 months earlier. Her diplomas and certifications were still hanging on the walls. Her medical texts were arranged on the bookshelf, and her desk was covered with the organized chaos of case files and treatment notes that had always characterized her work style. I opened the top drawer of her desk and immediately saw a sealed white envelope with my name written in Lisa's distinctive handwriting. My hands were shaking as I picked up the envelope and opened it. The letter was dated July 10th, just 2 days before Lisa's death. It was written on her personal letterhead and addressed to me directly. Dear Sarah, it began, I've been thinking about our conversation regarding Ashley Morrison's case, and I wanted to put my thoughts in writing while they were fresh in my mind. I know that Ashley's death has been weighing heavily on you, and I've watched you question your clinical judgment and competence in ways that concern me as both your colleague and your friend. That letter from Lisa confirmed everything Emma had told me about Ashley's case. Lisa had written detailed reassurances about our treatment decisions, explanations about why some patients can't be saved despite our best efforts, and encouragement for me to continue practicing psychiatry, because she believed I was helping more people than I realized. She had planned to give me the letter when she returned from her vacation, but she never got that chance. I sat in Lisa's empty office, holding that letter, and realized that everything I thought I knew about the boundaries between life and death, between reality and delusion, had been fundamentally challenged by a patient I had initially planned to treat for auditory hallucinations. Emma had somehow conveyed information that was impossible for her to know through any conventional means, and she had delivered a message that provided exactly the kind of closure and healing that I needed. 3 weeks later, I submitted my resignation from Riverside State Hospital, not because I had lost faith in psychiatric medicine, but because Emma's case had opened my eyes to aspects of human experience that traditional psychiatry couldn't address. I realized that some patients don't need medication or therapy. They need someone who will listen to their experiences without immediately trying to pathologize them. I now work as a private counselor specializing in individuals who report anomalous experiences. I help people like Emma find ways to understand and cope with perceptions that fall outside the boundaries of conventional reality. It's not traditional medicine, but it's the most meaningful work I've ever done. Sometimes the most profound healing comes from simply believing that someone's experience is real to them, even when we can't explain how or why. Emma Martinez changed everything I thought I knew about consciousness, death, and the mysteries that still exist beyond our scientific understanding. And sometimes, late at night when I'm working in my office, I could swear I feel Lisa's presence nearby, still helping me become the kind of doctor she always believed I could be.